Well, welcome everyone. My name is Shirley and I will be your moderator this evening. I am so excited to welcome Dr. Dawn Cohen, Chief Clinician Officer at HealthFirst, and Dr. Fiona Collins, a renowned dental infection control expert, as they discuss the essential steps of maintaining and monitoring dental unit water lines for safe patient care. Before we get started, I'd like to take a moment to go over some quick housekeeping. If you have a question, please go ahead and type it into the Q&A section, and we will answer them live at the end of the webinar. CE is not available for this webinar, live or in demand, and we will be sending out the video over the coming week at the end of the presentation. Doctors, welcome, and thank you so much for being with us tonight. I will pass it over to you now.
Thank you. Fiona, why don't you begin?
So good evening. It's a pleasure to be with everyone. And Dr. Dawn Cohen and myself are going to go through some of the relevant information on dental unit water lines that really emphasize the need for managing those, as well as options that are available and testing, of course. Our learning objectives include learning about the incidents that prompted the recent CDC HAN and implications moving forward, understanding current CDC guidelines, state dental board requirements, and recommendations for dental unit water lines. We'll review options for essential maintenance and monitoring of dental unit water lines, and you'll be able to discover valuable resources that can help you keep your practice up to date with best practices.
I'll throw one quick one here. As the Chief Clinical Officer at HealthFirst, we get lots and lots of questions on this, partly because HealthFirst is located in the state of Washington, which currently is the only state that actually has testing requirements in place by the dental board. But I will say that there's such a variety of questions that we're getting that I really hope that we put some of those to rest, and any that we don't, if you can't get to the end of this webinar, at the end, please enter it in and we will reach back out. We, and I'm speaking for Fiona on this, truly believe in this, but we also believe that all of our docs obviously want to protect our patients. And if we don't begin doing this properly, we put our patients, our staffs, and ourselves at great risk. Fiona?
Yeah, so one of the questions that comes up is, where are we now? And why was there, and what was the CDC HAN alert? So this was a health alert network from the CDC, which is relatively uncommon. In fact, it's rare. It occurred in March 2022, the event, and basically there was another outbreak of non-tuberculous mycobacteria in Georgia, which resulted in a cluster of infections sourced or caused by a pediatric dental clinic situation. So the objective of the HAN was really to alert every dental professional to this and to emphasize the need for the management of dental unit water lines.
And go ahead. If just a quick one. One of the things most of us in dentistry have read about several of these episodes over the last 5 or 6 years. Unfortunately, they're still coming. And it's hard to imagine why they should be. And that's, I think, one of the great purposes of why Fiona and I are doing this presentation tonight.
Right, and as you mentioned, there have been previous ones. There was one in 2015, another one in 2016. So it's not a new occurrence. And so at this point, they were emphasizing it, and quite drastic for the children that are affected. So extremely important. So we're going to look at transmission of dental unit water lines and the need for monitoring and maintenance. But not just against this background. Let's look first at some of the other issues that can arise. Dawn, we were talking about this earlier, what should concern us. So if you would like to take over at this point and start this discussion.
Well, as we talked about some of the pediatric considerations. We talked about pulpotomies, and the key culprit here is the Mycobacterium abscessus. On the other hand, if we look at that list, it's long. And the scary part, I think, about that list, as we look at viruses and we look at fungi, we don't have an accurate data piece of what's happening there. And the next is under allergens, there's a blank spot. The blank spot is there's always new ugly stuff coming. And we absolutely need to be prepared for what that is. The only way we're going to be prepared is to be consistent on our treatment of our waterlines and then the subsequent testing to verify that it's working. Fiona?
Right. And I think the other concern as we look at this list, as you mentioned, viruses and fungi, it's an unknown quantity to a large extent with dental unit waterlines. But of course, this is against the background of antimicrobial resistance, not just bacteria, but also fungal. And I know you've mentioned before, Don, about the Candida auris, which has not yet been found in dental unit waterlines, but there's been an outbreak of that where there was not a single antifungal drug that was effective, and it resulted in a significant percentage of people dying who had acquired the disease. So I think that background is important as well, that it's not just the large number of microorganisms that could be found, also their effect. But in addition, what can we do about it if it happens?
So let me ask you a question, Fiona. Why don't we have appropriate drugs that will kill, say, Candida auris?
Well, they're working on it, but basically we've been running out of drugs, not just for fungi, but also for bacteria because of overuse. Partly in agriculture, partly in animal feed and other sources with animals, but also overprescription. So it's a long history of overuse, unfortunately, and it takes time to develop more, and it becomes increasingly difficult.
And we in the dental community are conceivably part of this. I remember patients constantly saying, well, aren't you going to give me a prescription for pain? So they wanted their opiate without a doubt. And then going with the opiate, of course, I need an antibiotic. And it's really important for us to be part of the stewardship of what's right and what's wrong. And of course, to be able to explain that intelligently to our patients so that they truly understand what's appropriate and what isn't. Fiona?
Yeah, that's absolutely correct. There's been a lot of push from patients, including situations where, in fact, the antimicrobial would be ineffective because of the nature of the infection. I think the good news, if any, is that there have been reductions in the use of antimicrobials or antibiotics, both in the medical side and also on the dental side. And we're starting to see studies now that are showing there have been reductions with more knowledge and with stewardship. So that's the good news.
And you put, one of the charts you put up there is, I call it the circle of contagion. The reality is we need to break that circle. If we break that circle, we can truly protect our patients, ourselves, and our staff. But we need to do that, whether it's from wearing the appropriate PPE or just doing all of the things. We've seen all kinds of new high-speed suction, extraoral suction. These are a number of things that we need to do, but it's not just your patient or maybe your staff, it's us as well.
Yeah, and if we look at the entry route, one of the potential entry routes other than simply the water exposure from spray is actually in aerosols. And so there is the potential for aerosolization from the microbes in the dental unit waterline water, and then individuals acquiring those as an infection, at least transmission and then an infection. So that's something else that we need to be aware of. That was shown recently in a study from the UK where they looked at bacteriophages, so basically inserted viral components and bacteria together. And they actually showed that it could be found, and it was a laboratory study, that they could find those bacteriophages in the aerosol from the dental unit waterline water. So I think that's another aha moment, particularly in light of COVID-19. That was not found to be transmitted from dental unit line water, so I want to be clear about that. But that doesn't mean that something else couldn't be going forward. So to your point, what should concern us from here on? We don't really know. There could be other things that have not yet been found. So can we deliver safe dental care? Which patients? So we talk about patients, we talk about procedures and whether there's a solution. If you think about the patients, Don and I were talking about this yesterday, and the theory had been it was not harmful unless you were immune compromised. That's been somewhat debunked, hopefully totally debunked. We've seen it now in children who were not immune compromised. They obviously were elderly. And there have been other cases where it's not been only pediatric patients or only elderly. There have actually been 3 cases that I'm aware of from one study, and they were in Caracas. And it was a 21-year-old, an 18-year-old, and a 13-year-old, perfectly healthy, who acquired non-tuberculous mycobacteria during extractions. 2 of them were surgical and 1 was not.
You know, I look at this chart and it reminds me, I had a meeting with Dr. David Resnick, who's very often on some of these webinars. And David is blessed. David is the head of oral health at Grady in Atlanta. And he managed to, with whatever funding, to get constructed the most incredible facility that all of us would dream in, up to and including with negative pressure. He has the dream of what we all would love to have. We don't have that dream. And because we don't have that dream, we need to be that much more careful and to recognize that, and I go crazy on PPE. It is my belief that that is one of the things that we can do to protect ourselves the very most. And my classic on this is, well, everybody's got to wear long sleeves in a spray splatter environment. But does that mean that you go home wearing your scrub bottoms and then hug your little niece or nephew or grandchild? Because I don't know what patients you saw that day, but I don't think you wanted the young ones to meet them. So there's a lot of input here that we can do to make it the truly safest environment. And when we see the word safe dental care, I'm an OSAP guy. I'm on the board of OSAP, and I truly believe every one of our visits should be the safest dental visit.
Right. I mean, the situation with dental unit waterlines for patients, we really have to control those dental unit waterlines and the contamination in them. It has to be contained. Certainly, once, if anything's aerosolized, it's going to be an opportunity for patients, staff, and the dentist. But for the patients, it's absolutely critical. They can't wear PPE, so not while we're working on them. So it really has to be at the source. It has to be taken care of at the source.
And I'll throw in sort of right here for the fun of it. We hear about pulpotomies. Well, obviously, there you are. You have an open bloodstream. And we've seen 3 episodes where the sequelae were really terrible. Well, what we haven't seen, but I cannot imagine it's not there, if you have a contaminated waterline with way over 500 colony forming units of bacteria, what happens when you use your Cavitron and go beneath the gingiva for curettage and root planing? We haven't read about any of that, any of the perio stories yet, but I use the word yet very carefully.
Yeah, and there are some recommendations or some guidance on that was not there previously. So we're in a bit of a better situation. Obviously, for surgical procedures of any sort, dental unit waterline water should never be used. It should be sterile water or sterile saline or another irrigant, an antimicrobial. But when we look at the areas you're talking about, it's a little bit of a gray area. It's not a surgical procedure, but you are in contact with the vascular system, and you are using, in that situation, dental unit waterline water that could be over the limit. So if we look at that, one of the guidances is to use clinical judgment and determine it based on the patient's immune compromised status, basically, as well as the degree of exposure of the vascular system. That can be really difficult. It's pretty obvious for really deep pockets, for instance, and some other situations, phlebotomies is an example, or endodontic procedures. But it isn't so obvious in a moderate scaling and root planing. So what do you do? The safest thing would be to use sterile water or a separate source. Failing that, it has to be really well controlled.
Okay. What's our next slide, Fiona?
So in this one, we're talking about what's the difference. I think both of us have had the question. In fact, I know we've both had the question. Well, if it's municipal water, it's already within the EPA range. It's maximum 500 colony-forming units of non-coliform heterotrophic bacteria, preferably a lot less, of course, but that is the limit that's acceptable. So what's wrong with it if we're using municipal water? Well, we've got an image here of obviously the faucet, but also of a closed system dental unit. The difference is the faucet has wide tubing. It's used more often, typically more often, but it's wide tubing. If we look at the dental unit, whether it's a closed or an open system, I don't know how many of you have actually looked under the unit or beyond the unit to look at the dental waterline tubing, but it's less than maximum 2 millimeters in width. And so that's problematic. Probably none of you work 24 hours a day and the clinic's not open 24 hours a day. So that's a period of time when the water is stagnant. We only use the water during parts of procedures and not all procedures. So then it's stagnant also. So we're all used to thinking of dental plaque as a biofilm, which is exactly what it is. But that's what also develops in the dental unit waterline tubing. And I know, Don, you've been looking at dental unit waterline tubing for years as well. And it's a problem.
So, and when I think of it, and thank you for saying for years, pointing out color of my hair and so on. The reality on this is that when we think about it, before we started treating our waterlines, you would be off, let's say, for the weekend, maybe only for Sunday, and you'd come in on Monday and run your handpiece and go, what is that horrendous smell? That's what we're talking about. And at least now that we are treating our waterlines, that kind of problem tends to be eliminated, especially we know the guidelines also say we should be running our handpieces in between our patients for a significant amount of time to flush them out. Even though they have anti-retraction valves, it doesn't matter. They should be flushed between every single patient. Fiona?
I think sometimes it's a little bit difficult to visualize. You can smell it, as you pointed out, but it might be difficult to visualize. And on occasions I've said, well, think of a dog bowl with water in it. If there's a dog bowl with a little water remaining and you don't clean that dog bowl out for 2 or 3 days, maybe you've been away and you forgot to do it before you left and you come back, you've probably seen the brown slime around the bowl that doesn't just rinse off, you have to start wiping it off and then disinfect the bowl. Well, that brown slime is actually biofilm, very similar to a biofilm that you would see anywhere else. The only difference is that's a bowl, and this is very narrow tubing where the water flows through very slowly, intermittently, and it's faster in the middle of the hole, the lumen in the tubing, but on the edges, and this is the laminar flow, on the edges it's extremely slow, and it gives the microorganisms plenty of time to kind of hop out of the water, hop off as it's passing through, and they can adhere to the tubing. So that makes it more of a problem.
Yeah, 1/8 inch tubing does not align itself to be self-maintained easily.
Right. And the other thing, when you look at the image in the middle of the closed system, we can see there the water bottle. One of the other myths we've both come across is, well, we're using distilled water, or we're using tap water even that's within the level recommended by the EPA for drinking water. So it's a closed system, it shouldn't be a problem. But of course, that's not true either. The water can be sitting there, residual water, if you do not clean out the bottle properly and let it dry. So that can start building up microorganisms and lead to biofilm formation. On top of that, if you handle the bottles without wearing gloves, they have actually found that there are squames of skin, obviously with the associated microorganisms, if they're present, have been found in the water in dental unit water bottles.
Hey, Fiona, what happens if you don't have water bottles?
If you don't have water bottles, that you can still use, well, we can talk about that in a moment, I'm sure more. But if you have municipal system that does not use water bottles, it's directly to the chair. There are methods to deal with that as well. And again, it's still being through the tubing. So you have to treat the water between the municipal exit into your system and where it exits for patient care.
Yep.
So are there standard recommendations? We talked about this as well, Don.
Yeah.
And you mentioned Washington State.
And of course, Washington State has regulations they put in a little over a year ago. And it basically states that every 3 months, you need to test your water lines. And that may sound relatively simple until we realize, well, what are the water lines? It's not simply going to your high-speed handpiece, may very well go to your low-speed handpiece, your air water syringe, and your Cavitron, as a good example. So this is not the simplest, but right now it is a recommendation that meets most of the IFUs, instructions for use from the manufacturers, as well as recommendations coming out of organizations like OSAP.
Yeah, I think one of the issues there has been is there were no standard recommendations, and to an extent there still are not, because different states have different guidelines. The CDC has recommendations, the FDA provides input, OSAP has a white paper on dental unit water lines, but there is no specific dental unit water line standard. So that would be helpful. Hopefully there will be one in the future, but in the meantime, there is not. The other question we've both heard is, well, if it's a CDC recommendation, then we don't have to do it, do we? Well, the state dental boards, the majority, do promulgate the CDC recommendations, and it's a requirement for license. It's within the State Dental Act that you have to follow the CDC recommendations. So when they have done that, it becomes a regulation for that state. So yes, you do have to. But again, there are variations in the recommendations. We both talked about Washington State as a good example where it's very clear and very concise and gives the details.
You know, in New York State, I remember reading at one point, the CDC guidelines were included under state board, and violation was considered an ethical violation.
Yeah.
So this is all really pretty serious stuff, forgetting about the fact that the reason we want to do this is to protect our patients, the safest dental visit. But if you want to look at it on the outside, it protects your license as well.
Yeah, one of the areas that did have recommendations on frequency of testing earlier than many others was the US military. One example was the US Air Force. So that people were going to the US Air Force recommendations and guidelines and actually using those. So as we look at Washington State, it's really clear when we talk in a moment about testing, monitoring basically, and how to treat dental unit water lines and what to do. That's one example where you can go and look, and it's really clear what you need to do. You just need then to decide what you're going to use to do it.
Absolutely.
So Don, do the recommendations vary by setting? We've got different settings here.
And this is interesting. You put your practice in a spot that you decide. I think it almost becomes a marketing piece to your patients. This is what we do to make this the safest dental visit. And I'm a broken record when it comes to that phrase because of OSAP. But really, our patients do want to know what we're doing. And I remember, I think the worst evidence of that I've ever had in my practice years ago was a patient asked me, "Is that a clean cup?" And if you get a patient who's asking you, "Is that a clean cup?" you have a problem. You have a problem, not that it's not a clean cup, not that you're not doing everything right, but your patients are obviously uncomfortable. And I think it's crucial for us to explain in many ways what we're doing. COVID brought out some of this fairly well in that we started coming out looking like spacemen, and our patients tended to appreciate it and at the same time look askance, but they recognized that you were doing things. I think now that many of us are not insisting on face masks for all of our patients and all of our staff, although many offices are, the reality is our patients still want to know, what are we doing? Why are we doing it? And when you look at this list of recommendations, recognize that your individual practice is going to be compared against every other practice out there. I will tell you that I work with a number of the very large DSOs. They literally go nuts explaining to their patients what they are doing to protect them so that this is truly the safest visit. The dental schools and hygiene schools, this is their whole thing. This is how we learned basically originally, maybe not me, because I was there before we had to wash our hands probably. Not quite, but to that point, it really is incredibly important for us to spend time. We used to have a program where as a patient walked in, a new patient, we would basically say, as they walk past our sterilizing area, this is our sterilizing area. Everything is either one use or disposable or put in our autoclaves, which are the same sterilizers you see in a hospital OR. And we deliberately pointed this out. Then we'd come up with a steri pouch that had gone through the autoclave. So it's got our instrument pack in it. And then we take out one that hadn't been in there. See how the colors are light, see how the colors are dark on the arrows. That's how we know we're protecting you. That may sound like, oh, really, is that necessary? Think if you ever did a minor poll of your patients, they would really appreciate hearing that kind of thing. Fiona?
Yeah, it's true. Patients are definitely much more aware, they're much more interested. The clean cup was an early example, but there have been some well-publicized infection control breaches over the last decade. That has certainly caught the interest of some individuals in the public and some patients. And I truly believe that the recent COVID-19 outbreak made patients much more aware of the potential infection, not specifically in the dental office, but overall. But it has made them much more aware and much more interested in making sure they're safe where they go, including the dental office.
And you know what's interesting? In the dental office, if we think about it, we come out wearing gloves, a mask, a gown, eye protection. We're really doing the thing. I love it that when you go to your physician's office, about the only thing you got protecting you is some white bakery paper on the exam board. So it's interesting how we in dentistry have really adopted so much of this. But again, I think our patients really need to be made aware of how much we are doing for them to protect them.
Yeah. So the other thing that we can look at, of course, is what do I do? How do I begin? You could have a practice that has not been performing regular dental unit waterline treatment. You could have one that's got some level of treatment, and you have others that just want to be reassured that they're doing everything the right way. So what is the right way to get started? Well, understanding the need, I think we all understand the need, and review the recommendations. But again, there are variations, so you need to have a set of recommendations and follow them. First thing I would do if I were concerned or I was looking to do something in an office would be, and I wasn't sure which recommendation to follow or what to do, check with the manufacturer. So it's recommended that you check with the manufacturer of the dental unit, because that's where the dental unit waterline resides. If that doesn't work and they don't have specific instructions for use, the majority now do, but they don't all, then check with the manufacturer of products that are used to treat and to manage dental unit waterline water, and follow the protocols.
And again, another plug, you can always reach out to OSAP. They will answer just about any question you could think of that has to do with appropriate compliance. And never feel that you're alone, is what I'm trying to say. Because getting started is certainly the hardest part of this. What should I be using? Should I be using iodine? Should I be using silver? Should I be using daily tabs? Should I be using straws? There are any one of a dozen different solutions, and it is much better if you had the appropriate information that will leave you in a comfortable start that you could then carry on. Because the key to proper handling here is going to be consistent maintenance. And with that, of course, will be testing. If you do that, you will truly be protecting your patients. Fiona?
Yeah, I think one of the nice things about the OSAP white paper, in addition to what you'd already mentioned, is it gives you the different patient care scenarios, and it provides some guidance on those different types of procedures. So it's not patient-based, it's procedural-based. So it does give more guidance, and it gives you some protocols to select from without being prescriptive. So if we look at the right way to get started, we talked about the manufacturer. There are three basic aspects. One is testing to see what the level is of contamination in the water lines with heterotrophic bacteria. Shocking if it's needed to reduce the level of contamination. And when it's within the level, you need to maintain the dental unit water lines. So testing, shocking, and maintenance are the three, that's the triad that's required for dental unit water lines. So let's look a little closer at that. So what are our options, Don?
One second in there, Fiona. There is one other thing that comes in. We think about taking our street water and treating it, doing all the right things. Recognize that geography can play a huge role here.
Yeah.
And that's interesting, because depending upon where you live, say in the United States, if you're out in New Mexico, as a good example, the amount of dissolved solids that are present in your water can affect any and all of these technologies. So it's really important to understand, one, where you live, what the water quality is like. You may actually need some testing of the basic water, not in terms of bacterial contamination or CFUs, but actually what that water is like, and then move on from there. But without a doubt, moving on to testing. And Fiona, go ahead, please.
Yeah, I was just going to add on to your point about the water. If you've got hard water, that can affect the treatments that you're using on your dental unit water lines and affect it negatively. One way to find out about your water, obviously you can have it tested. You'd have to have it tested if it's well water. If it's municipal water, the municipality will be able to give you a water report, which will give you information on what's in the water. If you find it doesn't contain all of the information you need, you could still then get the water tested.
Very true.
So we're looking at testing. We have a couple of different options, and they're not exclusive for each other. Often we hear the question, should I use laboratory testing or should I use in-office testing? It isn't necessarily an or. So maybe we can start with the in-office testing. So when we look at in-office testing, one of the options, the main option, is a heterotrophic plate count. So that's been done in different ways. One of the popular ways to do this is to use, it's referred to colloquially as the paddle test, and you've probably seen it. So you basically have what looks like a paddle, a little paddle with a grid, and you have a sample vial where water would go in, and the paddle would be placed in the dental unit waterline water sample that's in the vial, left there for 1 to 2 minutes. Then the water would be removed. The paddle would be incubated. Now here's the rub. It can take 24 to 72 days or up to 7 days, depending on which test you're using before you get the results. The other difficulty, when you think about the paddle, Don, how easy is it to actually read that count?
Well, the problem on that is you read 400 CFUs. I read 800 CFUs, and one of our assistants read 900 CFUs. So the variation can be extreme. Why don't you think of taking blood pressure using a cuff? If you use a cuff, depending upon how your hearing is, how tight you made the cuff, you could very much get all kinds of readings. This is a similar type of situation.
Right. So it's almost like when you think about spore testing. You can do in-office and you can do laboratory, and there are advantages and disadvantages to both. When we look at the laboratory testing for dental unit waterline water, it's much more precise than in-office testing. However, there's a delay. So if you're wanting a fast result, the faster one is typically in-office. There's a caveat to that. There are now several laboratory tests that can be performed. 2 in particular are recommended. One is the R2A, or the Reasoner 2 agar, is basically what it is. And they will count the cultures. Now, again, there's the delay in sending it in, and there's the delay in the actual testing itself in the laboratory. The other option for in-office is flow cytometry. And with flow cytometry, you can actually get same-day results. So it's much faster, it's extremely accurate, and it uses laser technology. So that's another option. So Don, if you had to choose, what would you do?
I'd be glad that I am now a consultant, basically, in teaching, because the problem that you face here is, one, some of these solutions are more expensive than others. And we always want the very, very best results. It's not a simple solution. The testing is getting better. There are a number of different companies out there offering these. If I were recommending to an office what to do now, I would try to figure out, how can we do this in such a way that will yield the fastest, safest, most accurate results within reason. And you need to add all of those factors in there. At that point, I would make my choice.
Yep. And one option would be using the in-office test as a screening tool, because it is fast, but it's less accurate. So you could also do the laboratory test, which takes time, less time than it used to, is more costly, but is more accurate. So it's a question of balancing time, cost, accuracy, and finding the best way to get the information you need in a timely manner. I guess on the wish list would be a test that did meet all of the requirements that you talked about, that was highly accurate, that was very fast, that was inexpensive, and that didn't count both innocuous microorganisms as well as the pathogens or potential pathogens. So if you do an HPC or heterotrophic plate count, you're counting all of them. So you're not really getting a true picture of the pathogen level or the opportunistic pathogen level. So it would be lovely if we had tests that could actually differentiate and even go further and identify specific microorganisms, but we're not there.
You know, there's an interesting comparison to this. When we do biological spore testing, we think about, okay, you take the test and you mail it in to whoever you're doing your mail-ins. But by definition, a mail-in is a 7 to 10 or even 12-day process to get the results back. The other side of that is that you could do in-office testing, and that some of the new tests are actually 20 minutes long. They're that quick. On the other hand, that's not third-party verified. So I think you find yourself at times in that same manner where you might do the in-office testing, and then once every period of time, whatever you feel comfortable, do the mail out, and that mail out will then give you third-party verification and that greater comfort level.
Yeah, I agree. It's very similar. Even at the documentation level, it's very similar. So then we have, what's the frequency? So if we look at the recommendations, if you've had a repair or you're starting, or you've had a very high count, you would, the recommendation is to do this, perform this monthly. And once you're at a level that is within the acceptable level of less than or equal to 500 colony forming units per milliliter, to then start doing it quarterly. So now we come to the problem. Help, our test failed. Now what? Well, one of the questions, of course, and this again is similar to spore testing. Why did it fail? It might not be the microbial count, it might be other issues. So we talked about the paddle test, for instance. Well, you have antimicrobials in that water. So there is a portion of the test where you use germicidal neutralization. So you're basically trying to knock out the antimicrobial agent so that you are not getting a false negative. You can perform the test properly. Now, there will be instructions for use for when that is required. It may be supplied, or you may be expected to add it separately. So that's one thing that might go wrong. In this case, it wouldn't fail because you've actually got the antimicrobial in there. But what if you didn't incubate it properly? What if you incubated it for too long or not long enough? What if your sample became contaminated? What if there was another error that was made? What if you sent it in late to the laboratory? So there are many things that can go wrong that don't mean that you have a higher level of contamination. But now let's look at the test that failed because you did have a high level of contamination.
And when we one thing also, when we look at this, we recognize, where did we get the sample from? So you have 5 operatories and you have potentially 4 different sources of water. Are you going to test all 20 of those options every 3 months? Or are you going to basically use a conglomerate from Op1 to test, and then if that comes out clean, then the next period of time you'll use Op2 and so on. There are many variables in this that can make it reasonable and more economical, with a recognition that if you get a failure, you now need to break it down into much simpler numbers.
And that's one of the things that we keep talking about, the Washington state recommendations, but other recommendations as well, depending where you are. It's really clear. You do need to test all of the dental unit water lines. The question becomes, do you pool them or do you do them individually? You can pool up to 10 samples. It has to be from the same operatory, from the same dental unit. If you pool them and you get a failed test, that failed test could be from one of the dental unit water lines. So you then have to start looking at the individual dental water lines. But it does mean with the pooled sample that you can do one test for up to 10 lines within that operatory. If you do that, you have to use equal amounts of sampled water from each of the water line sources. You either need to do it straight from the dental unit water line, or if you have a device attached, it has to be a sterile device. Obviously, otherwise that's going to contaminate the sample. You should not use pool samples from different operatories. So those are the general guidelines that are contained in several sets of recommendations.
I'll throw one in there also. If you're doing any of these tests that are mail out tests, in general, you're given overnight packaging You're giving cold packs as well, so the samples don't get a chance to incubate. But the very intelligent thing on this is don't do any testing on Friday, because we still have to deal with whether it's FedEx, UPS, mail, anything. They're going to sit somewhere for a couple of days. So it's really important that you recognize best test results, most accurate, will come out on, say, Mondays and Tuesdays.
Right. So now we have the situation, it failed the test and it was contaminated. It was above the recommended level. So you would then shock the water. There are certainly dental unit water line. There are several technologies available for that, and several products that are available with instructions from use from manufacturers. So you would shock it in accordance with the recommendations and then test again. Did the shocking work? It's not dissimilar to shocking a pool to get it within the parameters you're looking for. It's quite similar, really. So you would test again and see whether the level has gone down sufficiently. If not, you would need to shock again. Once it's at the recommended, within the recommended level, you would then test monthly. Generally, that's the recommendation, and then go back to quarterly. You would also use the maintenance product. So people think, well, maybe if I shock regularly on a monthly basis, that's enough. Or maybe I don't need to do that if I'm using a maintenance product. But there is data available showing that the combination of testing and shocking when necessary and using a maintenance product is the best protocol and produces the best results in terms of keeping the dental unit waterline water within the recommended level. So that's guidelines there for the maintenance and the shocking and the testing together. Don, would you like to add anything to that?
Yeah, I think back to so many of the offices that I visited on audits and whatever. Bleach is not loved by our dental equipment. It eats our dental equipment. And I've seen many offices, as you've heard Fiona say numerous times, look at the instructions for use from your manufacturer of your equipment, as well as the product that you're going to use. The damage that can be done by using the wrong product is absolutely incredible. On the other hand, if you have super hard water, you really should be doing something about that rapidly, because that also can really do great damage to your equipment.
Yeah, and one of the paradoxes about bleach is if you're using concentrated bleach on plastics, that actually roughens the surface. So we're actually doing exactly what we shouldn't do, and the surface becomes roughened, and it's even more easy to colonize and for the biofilm to build up. So to Don's point, we need to be really careful what we're using and use the recommended products by the manufacturer.
You know, you have on this slide, you have new technologies, and I would label new technologies the same as new microorganisms.
Yep.
There is constantly stuff coming out there. For many of us, just look at something like ChatGPT. It is an entirely new world when it comes to asking a question. If you think asking Google's good, try ChatGPT. Well, the reality is we have a whole bunch of interesting technology. I think there's going to be a whole lot more better technologies coming out there, as well as the actual materials that are utilized in our equipment. So we're in an interesting age, and stuff is happening, but in general, good stuff. And it means we actually have to work a little bit harder to stay sharp.
Yeah, and in the meantime, we need to document really well. So the other question is, what do I document and for how long? So you should document staff training. Obviously, staff need training on this. You should document how you are treating the dental unit water line. So that should be what you're using, when you're using it, testing, shocking, maintenance, how frequently you're using it, and what the results were. The other question that comes up is, how long should I keep it for? I would check within your state how long you should keep it for in your state. General recommendation, and what Washington State recommends, for instance, is 5 years. So we really need to keep that document for 5 years.
You know, my favorite time of how long do I have to keep those records is SDSs, or in days of old, MSDSs.
Yeah.
How long do you have to keep them? And why would I have to keep them 30 years? That sounds absolutely ridiculous.
Yeah.
Since I'm the older on this call by a long shot, we used to use a product called Ward's 10-pack. Ward's 10-pack is a ZOE cement with a filler ingredient. The filler ingredient is really a winner. It was called asbestos. So the reality on it is, recognize record retention is a whole nother world. That's not what we're talking about today specifically, but do recognize we all should be aware of whatever we have. How long do we have to keep that for? For this, for documentation, by the way, there are a number of commercial entities out there that produce documentation. You should be using it. And part of that, unfortunately, is for legal protection as well.
Yeah. And the other aspect of using the commercial ones is it's standardized. It's easy to use for you as the user, and you know it's being documented. You know the documentation is being archived properly as well, so you have access to it easily. So again, if we look at dental unit waterline safety, we're focusing on safe patient care. We want to determine which options there are and what we want to do based on the recommendations for monitoring, maintenance, and treatment. We have to reliably maintain dental unit waterline water within the recommended level. And the less than or equal to 500 colony forming units per milliliter, the 500 is the maximum. If you can get much lower, that's even better. Research supporting effectiveness and safety of technologies, and continuous and effective risk reduction.
And to that last point, it's probably the most important thing in this. Once you start it, you must continue to use it, and you have to continue to monitor and test. If you do that, you at least can then look at it and say, okay, I got that covered. But
Yeah.
On my side, I would suggest let your patients know what you're doing, even on the water that we're using in our office.
So I think with that, we're both ready for questions and answers, or for questions.
Thank you so much, doctors, for that very interesting presentation. And yes, we are now open for the question and answer portion of the presentation. And I invite you and anyone who has a question to please go ahead and enter it in the Q&A chat box.
So I'm not seeing any questions at the moment. Don, what would you say was the most common question you're getting?
I think the point that you covered, and that is, we know we should be doing this. How do we start? And the failures, yeah, they're going to occur, but failures never occur if you don't start. And
Yeah.
I think,
Doctor.
I'm sorry, go ahead.
Oh, no, I interrupted you. Please continue. Please finish.
That becomes a key feature on this, and recognize there are a number of commercial companies out there. You might find that your supplier salesperson might have some ideas for you, but recognize whatever they are, look at the IFUs. Those three initials are incredibly important for us on everything we do. I would recommend, I do lots of lectures on emergency medicine. I might suggest that you look at the IFUs on lidocaine 2%, 1 to 100,000. How many carpules is it safe to give? Cool question. And in the interim, let's go back to this.
So there are two questions now. They're coming in on the Q&A actually. What's your opinion of using ozone to treat dental unit water lines?
Fiona, your thoughts?
My only opinion would be to check the manufacturer's instructions for use. I haven't heard of anyone recommending using ozone officially, but I would check manufacturer's instructions for use. And if it recommends ozone and it falls within the recommendations, I'm not aware that it does, I have to say, that would be fine, but I would not use it. I would use one of the recommended products that's available with support. Do you have anything to add to that, Don?
No, I totally concur. Totally.
Okay. The other is, what are the most common products to shock the system? Would you like to take that one?
No, I'd like you to.
I don't have the marketing data, so I don't know exactly what's the most common products, but typically it would be tablets or a solution that's added. There are many commercially available, so if you are interested in finding out, you could go to one of the dealers. Henry Schein has a list of different products that are used for shocking, for instance. I would ask the dental unit manufacturer what their recommendation is, and if it's in their instructions for use that, but what is the recommendation, and follow that. The next one is, sorry, Don.
It's interesting that if you utilize whatever appropriate measures are out there, most of the measures now are 24/7, 365. And if you use them according to those IFUs, you probably should not have to shock your system. I'm sorry, go ahead, Fiona.
I'm just looking at, there are a few more that have popped up, so I'm just looking at the next one. I think you answered in your presentation, but if my test is under 500 colony forming units per ml, should I be testing quarterly? Do you want me to take that one? I can take that one.
No, keep going.
Okay, so if you're under 500 colony forming units and you were previously over, then you would want to test monthly to check that you remain under and in compliance with the recommended level, and then you could test quarterly. If you have already been testing and it's under 500 colony forming units per ml, and you've been doing that when it's been within the parameters, then you could test quarterly. Again, look at the recommendations, and it will be really clear in the recommendations on testing monthly versus testing quarterly. The next one is self-contained water bottles. Test how often would you test the lines?
So I think we use the same recommendations consistently. And that word consistently is really important. How you treat your water lines and how you test them. Getting those down, getting those properly trained for your teams will become the ultimate success that you have with not having this as aggravation. Because as I said, the bulk of products out there are now 24/7, 365. So basically once a year, and that's it. If you need more than that, your dental suppliers like Schein can help you out with their techs as well.
Right, and if the self-contained water bottles, if we're referring to the closed system we were talking about with the water bottle, the recommendations for testing are the same, the frequency, whether it is municipal water or it is the self-contained dental unit water bottle.
I'm going to go to the last question that came up, and this has to do with using a straw. And it doesn't matter whose straw, Stericyl or whatever. The reality is you should always be testing according to appropriate IFUs. Whether you're using silver, whether you're using anything else, it doesn't matter. You should be testing, and the normal recommendations tend to be quarterly once you've established your appropriate 500 CFU consistently.
Yeah, and one of the other things to remember with the, I'll call them the straw products, is there are some that were quarterly, there are others that are annual, but if you look at the instructions for use, that annual is based on a volume throughput of dental unit waterline water. So if you are the exception and you're an outlier and you go through water much more, then you would need to change it more often. So you need to be aware of that as well.
Very true.
I think this is probably the last question. I turned in late and you may have addressed this, but if the office needs to use the canister to treat their water, how does the office shock their system? Manufacturers have told me that the office does not need to do. What is your recommendation? I'm not sure I understand that question.
I'm not sure either, but I can say that my answer tends to be the same. It's follow the IFUs and test quarterly once you've achieved the appropriate level.
Okay.
And for anybody who didn't get their question in, please feel free to email and we will respond back at a later point.
Thank you so much, Dr. Cohen, and thank you, Dr. Collins, for a wonderful presentation this evening. And thank you all for joining us tonight. We did record tonight's webinar and we'll email the recording out sometime in the next week. And we would appreciate everyone's feedback via our survey that will pop up shortly on your screen. Thank you all for joining us, and we look forward to seeing you on future webinars. Have a wonderful evening.